Now we have 3 minutes for the pros group to ask any clarifying questions and then come up for the rebuttal, okay? Go ahead.
Okay. Dr. Deb, a question about I think there was the first paper you presented on the polyneuropathy use for tafamidis. Could you what's the difference between the native and the non-native TTR levels? That's important for us to be able to expand on that.
In the study?
Correct.
Okay. So they found with treatment with the stabilizer tafamidis, the native levels increased and the non-native levels decreased, which is what you would expect mechanistically.
I'd have to read I'm just not familiar. What is native versus non-native TTR?
So native TTR is the normal form, and the non-native is the misfolded or deaggregated form.
So the non-native dropping could also indicate, inflammation or anything else going on there too. So that could also be what goes on. I have a question about, plasma lipids. Thank you for bringing that up. That was also our closing. So plasma lipids were measured since 1885, you said? So that's a long time.
So I'm not actually sure whether I said that.
So that's a long time to have that as a biomarker. So that's what we knew then to measure. And as we progress with our knowledge of proteins that are involved in the process of carrying cholesterol around, now we have tests that look at the carrier proteins and things like that. But we didn't know that then. So that's what we had to work with, I think.
Can we respond or? Yeah.
I think there's for them. There's the next phase.
That's next.
We can say.
Still have, do you have any more questions?
I think we also haven't measured the correlation between stabilized and total a lot, so we can't. I think one of you was bringing that up, that there's just not enough information, so it's not like one can be disregarded. It's only that we don't have the information yet. But we'll.
So could you repeat that?
The stabilized TTR and the total levels, they could be very well correlated. If we measure total TTR levels, we could be measuring stabilized levels. It's just there's not enough data yet to know that there's that connection.
Thank you.
Yeah.
And we're actually 5 seconds. I'm going to stop there. So now I invite the pro group to come up and make a rebuttal and try to convince this good audience that, yes, we should measure TTR level as a surrogate for assessing treatment response to stabilizer therapy. And you have 4 starting now.
Okay. So those are some very great points, fantastic points. I just one thing I got from thinking about that is, when you brought up the BNP use, and BNP is a great assay. We still use it commonly when I'm at the VA practicing there. We use BNP all the time. It has good prognostic use. It is not as sensitive of an assay as NT-proBNP. It's probably more clinically useful now in many scenarios. I would say that we know that there is some use, at least for this pre-albumin or TTR level. Whether you throw the baby out with the bathwater because it's not a perfect test is not necessarily, I think, valid either. Will it be the final test that is to be determined? And I would imagine no, probably will be less used in years to come as we develop more clinically readily usable and cost-effective alternatives that are trial proven, but with known prognostic data that's been published, could be related to multiple things. I think there's still much use and benefit in a lab value that can provide you more information.
So lack of validation doesn't mean lack of biological relevance. So the absence of validation doesn't negate that TTR has value as a pharmacodynamic biomarker. The limited discrimination that you brought up doesn't preclude utility. Confounding factors can be contextualized. They're well characterized and clinically interpretable, so we can look at those effects, inflammation, nutrition, and all of that. Mechanism aligned biomarkers don't have to treat with disease burden. So burden or organ recovery, but ongoing amyloidogenic risk stabilizers aim to halt further deposition, but don't reverse damage. So even if clinical deterioration continues, it's good for us to know what the organ damage is as a readout of the TTR circulating. So, and then guidelines, silence doesn't reflect rejection. So we just have to come up with the guidelines. And I think that's it. So
You still have a minute and a half. Last parting words.
Go team pre-amyloid. Pre-albumin.
I think
Right,
you're
okay.
done there.
Thank you. So
There you go.
now, let me just restart this. I invite the cons group to stand up or just stay where you are and give
Okay.
your rebuttal. And
So I'll start and then I'll hand
Sounds
it
good.
over to my relief pitcher, who happens to be Dr. Doroudgar's former advisor. Let me just remind you.
that's not fair.
But there was some information presented earlier today that was actually very informative. Actually, Dr. Doroudgar's summary slide. Multiple measures measure TTR levels and stability, but most are developed for research rather than routine care. Few assays are fast, standardized, or clinically validated for longitudinal patient monitoring. Immunoturbidometric assays are currently the most standardized approach, but may not reflect the extent of TTR stabilization under physiologic conditions. In clinical practice, TTR measurements remain largely trial-driven, with interpretation limited to circulating protein levels. TTR stabilizers raise circulating TTR, yet plasma levels do not reliably reflect tissue burden or clinical response. Effective disease monitoring requires integrated assessment, biomarkers, imaging, and function, highlighting the need for evidence-based guidelines and direct measures of amyloid burden.
So I want to end with thanking the pro group by helping out the con group, as you just heard. But I think this emphasizes that sometimes there's no simple answers, and sometimes in between is where we end up. In my mind, what I think about when I was asked this question about whether TTR levels should be a biomarker for, there kind of the basic way of putting it is more development has to be done. And yes, it's true. I don't think we ever use any one biomarker as a complete diagnostic. So in combination with other modalities is the most useful way. But thinking about how complicated the TTR chemistry in the blood is, again, reminded me of the complexities of, well, we talked about BNP and lipoproteins today. Not lipids, lipoproteins, and cholesterol-containing lipoproteins, which were discovered much later than cholesterol, of course. And so until those assays were beaten up in the research lab every which way they could be, and then validated in the research lab, and then validated in clinical trials, were they able to be used continuously as biomarkers. And so I will say that the way the biomarkers are assayed has to be uniform from lab to lab and study to study. In clinical trials, the way the patients are identified has to be uniform if we're ever going to be able to figure out anything from biomarkers in those clinical studies. And then the type of drugs that are used to stabilize, We only have 2 right now that are FDA approved. There's going to be more in the future. But I would end by saying, even though we argued con, measuring TTR, levels of TTR isoforms is going to be important in the future as a diagnostic.
Thank you. You had 15 seconds left. You guys are doing great. So now, thank you to our pros and cons group for researching this topic and giving us the yes or no. And now it's up to our audience. We need the QR code. Now I need you guys to decide, were you guys convinced that yes or no, TTR levels should be?
You helped, you helped convince them at the end with his last sentence.
Yep, once we have most of the responses, Renee can let us know, yay or nay.
The winner pays for dinner tonight. You only vote once?
Yes, sorry.
It's rigged.
Is it giving you numbers or percentages?
Can we still say things? Can we
Oh.
still say things?
No, it's over.
Perfect.
Did you have parting, but yeah, people are voting already.
The question should be pro or con or maybe. I don't know.
All right, Renee, here. You can let us know who won. Who made the better case?
Okay. Nose.
Do you have a percentage? How was it compared to before?
More nose.
Sorry. So there we have it.
You know, it
So,
changed somewhat.
so maybe you guys, so maybe you guys,
Give me numbers.
I know. Well, so now I'm thinking maybe the pros did help the cons. I'm sorry. So, but thank you so much. And thank you for our audience for playing with us. I hope you guys learned something or made it think about this topic. We appreciate you. And I'm going to give the mic
job.
to
job.
Dr.
Really good
Deb
job.
for parting remarks.
Okay, I've never ended on time and early. It looks like,
Are we early?
yes.
She told me to stop talking.
Well,
else
I
you wanna
think
see on purpose?
this is more time in the patio. So I just want to thank everyone for participating and spending time with us and all the work that went into this. And I learned a lot. I learned about diagnostic odysseys. I learned about patient resources. I learned about clinical trials. I learned about pathology. I learned about the importance of the multidisciplinary approach. I learned about barriers to care in the community. I learned about some new research in our abstracts. I learned a lot about TTR. And I learned from our support group with a lot of challenging questions. And there were a lot of discussions that I missed because of all the things going on. And I think, to me, that's in some ways the best marker of a great meeting, when there's so many conversations going on that you can't even keep track. And so I want to thank you all, and please join us next year. And for the next 1 hour, we'll be on the patio if you'd like to join us for the reception. So thank you.